this week on the BackTable podcast.
Yeah, I think for a distal tumor, there's few things that I hope for. If it's so distal that I can do a TUR of the UO and possibly get it, I'm always excited to be able to do that because I feel like it's probably safer than a semi-rigid ureteroscope trying to do a biopsy. But if it's kind of, above that, it's outside the tunnel in the ureter, I'll use the semi-rigid. I remind people all the time that the semi-rigid ureteroscope is a weapon, right? It's a two-handed device. You have one hand out on the far end and one hand back at the back and a 2-point fulcrum, security, and just be as cautious as you can. But the distal ones are tough.
Hello everyone and welcome back to BackTable Urology podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. Now, a quick word from our sponsors. BackTable Urology is brought to you by Urogen Pharma, the maker of JELMYTO, a mitomycin pyrrolocalcium solution, the only FDA-approved therapy for low-grade upper tract urothelial carcinoma, or UTUC. JELMYTO can be used alone or as part of a multimodal approach with resection or ablation. In the Olympus study, JELMYTO demonstrated a complete response in 58% of the patients. The most common adverse reactions were ureteric obstruction, flank pain, urinary tract infection, hematuria, abdominal pain, fatigue, renal dysfunction, nausea, dysuria, and vomiting. JELMYTO was studied in adults with treatment-naive and recurrent low-grade UTUC and can be used in a diverse population of patients with low-grade UTUC. JELMYTO is contraindicated in patients with perforation of the bladder or upper urinary tract. For full prescribing information and additional important safety information, visit jelmyto.com/ACP. Now, back to the show. This is Jose Oche Silva as your host this week. We have Dr. Katie Murray. Dr. Katie Murray did her residency at University of Kansas Medical Center. After this, she went on to do a fellowship in urologic oncology from MSK, Memorial Sloan Kettering Cancer Center in New York. And she's currently a urologic oncologist at University of Missouri. Kato, welcome to BackTable.
Thank you so much. Thanks for having me.
No, thank you. So today we're going to talk about upper tract cancer. Is this your main focus? What do you do in your practice?
Yeah, so I practice all urologic oncology, but I do see a lot of patients with upper tract disease, despite being, in a smaller town here in Missouri. And so do have a very recent experience in treating quite a few patients with upper tract urothelial.
Good. So what is surprising to me about, now the AUA has all sorts of guidelines, but there's none for upper tract cancer. If you were to guess, is it something that is infrequent? Why is that?
Yeah, so I think, it's interesting, like you state that the AUA does not have guidelines for upper tract disease, right? This is in contrast to the Europeans who do have some, set out things for upper tract disease specifically. If we go back in time, I think that so much of what we did in upper tract was directly related and just assumed from what we know in bladder cancer. We know now in 2022 that's probably not correct, and in many ways not correct. And so it leads us as urologists, especially here in the United States, depending and relying on, extrapolating from bladder, but then also looking at our NCCN guidelines and those European guidelines to help reference our practices.
Yeah, it seems like we're always behind. They do for the Europeans do them first, and then 5 days later we come up with ours.
That's right.
So because also I think that the same thing for testicular. We're still waiting for testicular cancer guidelines. So let's talk about the upper tract and what you do in your practice. In terms of the initial evaluation, are you seeing these patients de novo, or most of them are referred to you already with the diagnosis?
Yeah, I see a good combination. So probably half and half of what I see. I'm in mid-Missouri. So as a urologic oncologist, a good chunk of patients that I see do get diagnosed with upper tract or some disease from a general urologist, and then they get referred in for treatment or for surgery. That being said, there's still large chunks of patients who you're seeing for their gross hematuria workup. You're seeing for their microscopic hematuria workup. And guess what you find? You find bladder cancers. You find upper tract urothelial cancers. And so you're finding those de novo at the same time.
And those patients, when you were doing microscopic workup or hematuria workup, you're doing the CT urogram, cystoscopy. Are you doing cystoscopy in these patients in the office with blue light, or what are you doing, just regular cystoscopies?
Yeah, so I actually have, I do a regular cystoscopy. At our institution, we have Olympus towers and Olympus scopes. So I use routine cystoscopy with the option of narrowband imaging or NBI technology as an enhanced cystoscopy. Part of that, I think, is important for whatever technology you have for enhanced cystoscopy is to use it on as many patients as you can just to get that experience, and so NBI does have the capability of being able to, flip the switch and not do that preoperative preparation with a catheter in the cyst view. And so you can flip over to NBI and take a quick glance at patients' bladders with that. So I will do that on a majority of cystos that I do. Part of it's for my own experience. Of course, I'm at a training institution as well. And so to see that with that enhanced cystoscopy, but definitely CT urogram, cystoscopy for those patients with gross hematuria, and then a majority of patients, especially if they have any sort of risk factors, older age, previous history of smoking, any family history, we're talking about doing that for microscopic hematuria as well.
And those patients that, for example, let's say you do the urine cytology is negative, but they continue with microscopic hematuria risk factors. You do retrograde, and for some reason you cannot do some contrast study. Are you doing retrogrades? Are you doing ureteroscopies on these patients? Because it seems like it's changing all the time in terms of the guidelines.
Yeah, I think that's a great point, and it's always a question. And, part of it is dependent, like you said, on the patient's risk factors, but also with that is the patient's comorbidities, right? How much and what are you looking for? So if I have a patient with, just microscopic hematuria, and we have non-axial or non-invasive imaging with an ultrasound that shows no hydronephrosis, a cystoscopy is negative, I may send a urine cytology. If that's negative, I will forego retrograde pyelograms. Of course, any gross hematuria changes that. Otherwise, ongoing microscopic, seeing, and repeating a workup every couple of years.
Okay. And in those patients that you do find something, let's say, if you do a retrograde and you find a feeling defect, would you do a cystoscopy at the moment so you get the consent for also doing retroscopy with some sort of biopsy?
I would. I would go ahead and proceed to do it at that point in time. That's when I make the comment that I'm from Missouri. We're known as the show me state, so I want to look and see it with my own eyes.
Okay. And those patients that, let's say, that patient that you were not planning on finding anything, but you had the risk factors, is in the OR, you decide, okay, so let's go in and do ureteroscopy. In this, would you do a rigid, flexible? Is there a difference?
I would use a flexible ureteroscope so that I can ensure that I see the entire ureter as well into the collecting system. I would not use a semi-rigid unless I had somebody who I had some suspicion that there was a more distal filling defect or something that I thought I could really just focus on the bottom half. Otherwise, I'm going to put a flexible ureteroscope, preferably without a ureteral access sheath at that point in time. We can get into that later if you find something and you're going to do an ablation or a treatment, what you do with a sheath then.
And in those patients, so let's go ahead and talk about a patient that you already know has something there, the CT urogram came back with some sort of filling defect. Most likely there is a mass, let's say, that is not infiltrating into the parenchyma, a filling defect in the renal pelvis. What do you tell the patient? What are you going to do? What's the planning for that patient?
Yeah, so, that's the patient that I'm sitting in clinic. I have the CT urogram in front of me. I show them the pictures, right? There's clearly something blocking the drainage, right? It's not filling up right here. So I'm going to take you to the operating room. We get multiple things with one operation. I get to look inside your bladder at the time. I evaluate that. If there's anything inside your bladder, I'll take care of that at the same time. I'm going to throw the ureteroscope or run the scope all the way up your ureter so I can see that entire tube and then up in your kidney. First things first, I'm going to take a biopsy of that. Those are hard biopsies for us to get, and I kind of explain that to the patient, off the get-go, that we may have complications in kind of getting that tissue and what kind of scope, French we're working through and what we're dealing with. And so, we'll talk about that, but attempt to do a biopsy. If it looks to be something that I can easily endoscopically ablate, I'll tell the patient, if it's something I can take care of, I'll try to take care of it right then and there on the spot, right? So you get it all for one. If it's something that's large and I just can't take care of it through the scope and may require more of an operation or other treatments, I'll get my biopsy. I'll make sure we don't have a lot of bleeding. We'll stop. I'll go talk to your family after surgery. We'll all sit down in a week or so from now and have this kind of sit down conversation of what do we do now and go from there.
And in those patients, are you using an acid sheath for the biopsy part, or you're just going straight with the flexible and then using like a Parana or something to get the biopsy?
Yeah. So my preference is if I know somebody has a tumor and I see that on urogram, I like to put a ureteral access sheath, because I also think anytime you're using a Parana, whether you're using a big opsy, whether you're using a basket, we can talk about ways to get biopsies, dragging that down the ureter, I feel like even in the access sheath in and of itself is less likely to fall off of your biopsy than running it down the ureter through the bladder and down the prostatic urethra for that matter to get a good biopsy. The other idea, of course, is it's a cancer. It's urothelial cancer, right? Urothelial cancer can implant anywhere along the urothelium. And so, you get a big biopsy. You don't love the idea of running it down the entire rest of the ureter.
And in let's say a patient that for some reason, just like with stones, sometimes you cannot go into a ureter. Will you put a stent and come back later, or what do you do?
Yeah, great question. I personally am not a ureteral dilator, so I will not balloon dilate just to get access to somebody. Now, that always brings up the question, do you really want to stent somebody that you think has an upper tract tumor and seed it down to the bladder? I feel like for the limited amount of time that you need for a stent, to dilate that ureter to be able to get a ureteroscope up, it's probably fairly low risk. And so I will just stent those people, bring them back in 10, 12 days, something like that for my ureteroscopy. The idea of doing a balloon dilation or something that's more aggressive than just a regular ureteral access sheath type dilation, if you can't get it, you haven't seen inside that ureter. You haven't seen if there's, could there be a tumor there that's, concentric, that's compressing that ureter. And just the idea of balloon dilating doesn't sound great to me.
True. Balloon dilation without knowing actually what is there. It can be, like I said, multiple things, not necessarily a stricture, a stone, something else,
right.
Anything else that can be there, and you can create more damage. So let's talk about, you mentioned the ablation and at that time. So guide us through the process. Are you use a laser? What do you do when you're there in that kidney and you say, well, it's something small, let's do an ablation, try to see what's going on?
Yeah, so, you're up there. If you've just taken a glance, I will go back, like I said, and put that ureteral access sheath in if I can. Otherwise, you're working through your normal flexible ureteroscope. You're up in the renal pelvis and you ask for your laser. I'm using a 150 to 200 watt laser, obviously something that'll fit through your ureteroscope. With tissue settings, I don't think that it matters the type of laser. There's lots of lasers out there. There's with Moses technology, now there's thulium lasers that may be a little bit better with coagulation and those type of currents. But, my idea is always to get down to the base of the tumor and, you try to resect it versus just scattering and shattering things everywhere and doing that as much as possible until you see no obvious tumor. One thing that we haven't talked about is how do you manage your visualization, right? A pressure bag versus a pump system. At my institution, we use a SAPS or a single action pump system with the syringe to keep that irrigation flowing. That being said, I think it's extremely important to have, communicating with the person that's doing that to not push too much pressure, big bursts, into the ureter, into the kidney at the same time that you're doing those ablations. But it's got to be enough that you can see.
Is there a risk of metastasis because of the pressure? I mean, are you pushing cells towards the kidney?
That's always a concern on our minds. I think it's the same as, if you're doing a stone and somebody's got an infectious stone, right? It's what you're worried about. And so the problem is we don't know what that pressure is as a urologist, right? We have in our minds, the perfect amount of pressure, not too much pressure. And maybe that's where a pressure bag for some individuals could be advantageous. But I've not ever seen that. Of course, is it in the back of your mind? Always.
And let's talk about the biopsy. I mean, what is a good biopsy? Sometimes with the piranha, maybe you think you get something, but really it's not there. I mean, how many bites do you try to get? What for you will be good?
Yeah, if I can get out a piece of telfa and I can get a biopsy that is visible to the naked eye on that, I'll feel pretty good about it. Now, one thing that I do always think about is if you got a really papillary tumor and you grab the top edge of it and you pull it out, it's going to be very papillary, right? And sometimes that will be a low grade. And so if it appears to be something that I'll take that top half off, maybe do an ablation, and I may try to get something even a little bit bulkier, a little bit better at the base. You just mentioned the piranha. Not a great, it's pretty microscopic. You're using a little hypo needle trying to dig it off there and put it on a piece of telfa. I've gone as far as using a marking pin and putting a permanent marker kind of around the circle so the pathologist can find it. So I will often use a stone basket for ureteral biopsies or renal pelvis biopsies. The problem with those is they do get that papillary kind of fluffiness that's on the outside of the tumor, and a little bit harder to use one of those baskets down at the base where you might need to get your piranha out.
So any specific basket do you use, or?
I just use a 0-tip nitinol basket, and mostly that's because that's our number one go-to basket for our stones. I do think there's a few other baskets, I couldn't even call them by name, that I've seen out there that may give you a better grasp, but I've been fairly successful with the nitinol.
And for tumors that are in the ureter, let's talk about a distal mass. Do you do the rigid and then just try to be careful not to do any trauma to the good ureter or the prostate or that area? What do you do in those cases?
Yeah, I think for a distal tumor, there's a few things that I hope for. If it's so distal that I can do a TUR of the UO and possibly get it, I'm always excited to be able to do that because I feel like it's probably safer than a semi-rigid ureteroscope trying to do a biopsy. But if it's kind of, above that, it's outside the tunnel in the ureter, I'll use the semi-rigid. I remind people all the time that the semi-rigid ureteroscope is a weapon, right? It's a two-handed device. You have one hand out on the far end and one hand back at the back, and a 2-point fulcrum, security, and just be as cautious as you can. But the distal ones are tough.
And you mentioned the resectoscope. In those cases, what do you do? Do you put a stent first or just resect over and hopefully there's no obstruction?
Yeah, if it's something that I'm really concerned, I'll put a ureteral access catheter, like a 5 French, or 6 French open-ended catheter, and put it in and try to resect around. Otherwise, just our normal principles of TURing somebody, right? You want to get a good specimen. You want to go fast enough that you're not burning up all your tissue, but not so fast that you're bleeding like stink, before you end.
Okay, I forgot to ask you, any specific preoperative antibiotic that you give these patients or just the same as any ureteroscopy?
Yeah, just the same as any ureteroscopy for these individuals. One thing that we haven't really touched upon that I think, we don't talk about very often in urology, and it's not really in any of our guidelines for patients that have endoscopic ablations, but that I'll often discuss with patients is giving an intravesical chemotherapy immediately postoperative after an endoscopic ablation of the upper tract, right? So doing a postoperative dose, gemcitabine, or if you're a mitomycin user still, mitomycin after that ablation because you've ablated those urothelial cells are making their way down via normal drainage. So I will discuss that with patients at the same time.
So you're talking about that preoperatively, but while you're there in the OR, when do you decide, you're going to do you do it like just for like mitomycin for the bladder? Are you doing it on everybody as long as it doesn't look like there's a gross perforation or anything like that?
Yeah, my routine is to do it as many people as I can. I use gemcitabine. That's my routine. And since I've really been out in practice, when the trial came out, I switched to gemcitabine kind of right away. And I've always used that. And as long as I don't have an absolute contraindication because of resecting too deep or ablating, worrisome and seeing fat or something, then I'm giving it.
When will you leave a stent on a patient? I mean, let's say you do a resection. When will you decide whether, okay, so this patient, I'm going to stent it?
Yeah, if I resect a ureteral orifice, I'll probably leave it, just for a short period of time at least. If I've done an ablation in the upper tract, again, I'll probably leave it in a majority of situations, but with a string, just for a temporary period of time, just because I put that ureteral access sheath in just for that edema issue or any residual bleeding that they may have. If it's a person who I've done a larger ablation on, I may leave the stent because I have plans to come back and complete an endoscopic ablation a few weeks down the road.
So let's talk, are you doing percutaneous resection? Is there a role on percutaneous resection?
Yeah, there probably is a role. I personally don't do percutaneous resection. I have those patients that come in every once in a while and it kind of perks your interest and you think about it, you discuss it. But no, I've not done that.
Okay. So again, if there was a guideline, maybe we'll know whether it's something real or not. So let's talk about when will you decide, okay, so this patient is going to end up losing the kidney or doing a nephrourethrectomy. When do you decide that? I mean, is there a patient just with the CT scan that you say, okay, it's not worth doing a biopsy? Is such cases exist?
Yeah, so personally, and part of this is just the way that we practice, I like to have a biopsy. So even a patient who has, a big, bulky mass, again, I want to look up there and have a biopsy. And that makes sense to patients, that you have a biopsy before you go taking out a large organ, the kidney, that can impact their future and impact, renal function, their diabetes, their hypertension, everything else in their life. So I prefer to do ureteroscopy with a biopsy of some sort in those patients.
Okay. And are you doing gemcitabine for everybody, even if they still have tumor, or just for patients that you're able to resect everything?
Yeah, just for a patient that I feel like I get, all of the tumor and I'm not headed back, or I'm not planning to do a nephroureterectomy, or I'm not planning on doing an intracavitary, chemoablation on their upper tract in the future.
Okay, so and let's talk about that. So let's say it's a low-grade tumor.
Okay.
And you're able to resect everything. What are the options for this patient?
So I think low grade is, you've mentioned multiple times about guidelines. And so one thing that the Europeans have is they have some risk stratification for upper tract disease that we don't have in our AUA guidelines. So we have it in bladder cancer. We talk about low risk, intermediate risk, high risk, but we don't have that in upper tract disease, and the European guidelines do. And so they talk about low risk patients, which are low grade patients with a negative cytology, with smaller tumor sizes in the collecting system that are also a good indication for nephron sparing, i.e. ablations, or whether that be an endoscopic ablation, chemoablation. So somebody's low grade, I've ablated them to completion. I'm going to talk to them about the ongoing concern for recurrence, right? Recurrence rates are high with endoscopic ablations, pushing over 50%, and pushing 70% nearly for those ablations. But is there something else out there? And I will talk to them about intracavitary chemotherapeutics, right? In today's world, it's since 2020, that's JELMYTO, and what that looks like for that patient population. So we're looking at a 6-week induction course of JELMYTO with or without maintenance therapy of that ongoing for these low risk or low grade patients versus ongoing endoscopic ablations, right? Because that recurrence is going to happen. It's pushing, like I said, 70%, in large studies of patients with low grade disease.
And what are you doing for the patients on JELMYTO? I mean, are you I think you can do it like a nephrostomy and inject it weekly. or also take the patient to the OR and just do a retrograde? What's your practice?
It's a cool new thing that's chemoablative that gives us options for our patients, right? So I've done a mixed bag. I've injected both ways, but 80% of the patients I've treated with a nephrostomy tube. So JELMYTO's not any different than other therapies that we're used to as urologists for urothelial. It's a 6-week induction course, right? We know the number 6. That makes sense to us. We can explain it to our patients. It's just how you physically get the drug to touch the urothelium. Do you do that by doing a cysto once a week with a ureteral, catheter up into the UPJ to instill the drug, or do you do it directly through the back through a nephrostomy tube? I've done it through a nephrostomy tube for a majority of my patients that I've treated. A little bit for convenience, a little bit because the patients don't want to have cysto every week for 6 weeks, a little bit because I don't have fluoroscopy available, right then and there in my clinic, right? And if I know I have a nephrostomy tube in place and I know that it drains urine, it's in the correct location, and I can safely instill my chemotherapy.
And in terms, so after, will you do just the same like it was the bladder? So let's say after 6 more weeks, you do a ureteroscopy, take a look inside, or how will you go about that?
Once a week installation for 6 weeks. If the patient has a nephrostomy tube, I bring him back 1 week later and pull that tube just to get the tube out. And then I'm looking in the kidney, direct visualization with ureteroscopy about, 6 weeks after completion of therapy for that direct visualization.
Are you doing biopsies usually with these patients? I mean, is there any change? Just like, let's say, a patient with BCG, that sometimes you get that reddish discoloration that you're not sure whether it's recurrence or, eventually you understand that it's just the reaction for the BCG, but are you getting some sort of reaction that you don't know exactly what it is?
So interestingly, in contrast to BCG, I found that the JELMYTO or the chemotherapy that you put up there, I've seen not really a redness. I've kind of seen a yellowy brown necrotic look, within the kind of at the papilla or in the renal pelvis that I've kind of termed as my classic appearance post JELMYTO, at that first 6-week follow-up. I look again 3 or 4 months down the road, and those seem to resolve themselves. I don't do any biopsies except for cause, meaning if I see a tumor, I try to get a biopsy to ensure I'm not dealing with a high-grade tumor now. A cytology is always a good idea to do as well, right? Not that a cytology is going to find your low-grade cancer, but it's going to rule out, ideally, your high-grade tumor that you maybe are missing.
And this is indicated for low-grade also in the ureter, right?
It's low grade of the upper urinary tract. So by definition for us as urologists, that's the ureter as well as the renal collecting system. Interestingly, in the clinical trial that got JELMYTO approved by the FDA back in 2020, there were no patients who had ureteral tumors in that trial, but it is approved for the entire upper urinary tract. So that includes ureter as well as renal pelvis and calyceal system.
And for patients that have like a solitary kidney, safe?
I've treated several patients with solitary kidneys with this, and it's weighing out the risks and benefits. The impact of JELMYTO to the kidney itself has been, deemed to be very safe. One thing that is very important to discuss is in the clinical trial, 17% of patients required intervention for ureteral stricture or stenosis, right? So that could be very important for somebody with a solitary kidney for what you're dealing with. So definitely something to consider. Make sure you're not obstructing that solitary kidney in those individuals.
And it was because of the JELMYTO or just because of the ureteroscopy?
Hard to say.
Yeah.
In the trial, all the patients were treated via ureteroscopy and all patients were treated via, cystoscope. And that is it, 6 weeks in a row of a trauma to the ureter, or is it the drug itself? Hopefully ongoing studies will tell us what that answer might be. Can you prevent it by, maybe giving steroids? Some people have talked about, can you give, should you leave a stent in each week between installations? In my situation, I've treated so many of these patients now via nephrostomy tube, and that's a great pop-off valve, meaning if the patient has pain or stricture-like symptoms, they can, I keep the tube capped. They can uncap it and drain it, right? And then it doesn't require a ureteral stent.
Okay, so even though they have the nephrostomy, you don't put them on a bag. It's just for purpose of the chemotherapy.
It's truly for access.
Okay. So let's talk about high grade now. What are the options? I mean, so compared for a distal high grade in the ureter versus a high grade in the renal pelvis, is ablation still an option, or those patients are going to end up with a nephroureterectomy?
So, I would caution people to jumping in and doing just ablations on patients who can have other things for high-grade disease, right? And a couple of things that always come to mind that I really think about is we can't forget that high-grade disease, especially in the ureter, it doesn't have that backing that we have in the bladder. It doesn't have muscle around it. It's in the ureter or it's out of the ureter. And so, one thing that I always remind is don't forget to do your staging. Don't forget to check your pelvic nodes. Don't forget to look at your chest. I prefer to do a CT chest and all of the rest, abdomen and pelvis on any patient with high-grade disease, no matter where it's at. I will do ablations on people with high-grade disease, but those are the people with absolute contraindications to having something else. Our solitary kidneys are disease on both bilateral disease. Our patients who you do a nephroureterectomy or even you do a distal ureterectomy, you're worried about putting the patient on dialysis, something like that. But absolute discussion that the standard of care is taking it out to completion. Is that a nephroureterectomy on distal tumors? It's probably a distal ureterectomy with a lymph node dissection and a ureteral reimplant.
Okay, so those patients, well, again, there's no guidelines, but so a patient, let's say both kidneys are fine, he's not diabetic, good renal function, a distal ureteral mass, high grade, you will offer distal ureterectomy?
Absolutely. One thing that I am always, and this is mostly for myself, for surgical preparation. Again, we said this at the beginning. If you see the mass obvious, do you require the patient? Do you make yourself look with a ureteroscopy? And I do. I take all those people back. And part of it is I want to see how high that tumor actually goes and try to do a really good retrograde to make sure, am I going to have to reimplant it? Am I going to have to hitch up the bladder, on the psoas or do something more extreme to get that ureter reimplanted?
And when you're doing the nephroureterectomy, I mean, just plain ureterectomy, in terms of the bladder cuff, are you doing something? I remember that at some point, some people were doing TURPs or TURBT on that UO and then doing the reconstruction. I mean, is there something like a standard right now, or with robotics, it changed and you can do a very good resection down there in that area?
Yeah, so I think, when that really became popular was, we were really talking about laparoscopic surgery and trying to keep people from having to sew laparoscopically, right? So I do think robotics has changed the game on that, because you can get a really good bladder cuff and you can get it watertight, sewn back together without any problems. So if you're doing a robotic nephroureterectomy, it's hard for me to think in my mind of a time or a reason that you would need to do, a Collins knife resecting the UO with a TUR type procedure before you start on your nephrectomy.
And are you leaving any drainage in those patients, like a JP drainage when you close the bladder?
Yeah, I do, but I'm a drain placer in a majority of my procedures. A straightforward radical nephrectomy, I wouldn't. But anybody that has a potential for a urine leak, I've opened the urinary system, I'm going to leave a drain. Now, these patients only stay in the hospital for a day or two, right? And so it's probably too short of a time period to catch a leak anyway, but it just makes me feel better.
And the role of neoadjuvant or adjuvant chemotherapy in these cases, what's your take on that? Are you doing on everybody?
Yeah, so it's really hard to get a pathologic diagnosis on a biopsy alone that's going to, convince your oncologist that you really are dealing with T2, T3 disease of the ureter, right? Because you just can't get that ureteroscopically or endoscopically. And so if you have an oncologist that you work with, I think that you guys can do that. but it's definitely an implication. So really on the patient who has questionable renal function, knowing that I'm going to take a hit after I get that kidney out, I'll really push that neoadjuvant if I know it's high grade and it looks to be a big, bulky tumor, and push for that. Otherwise, sometimes you can only get what you can get. And so proceeding to surgery and plus or minus adjuvant chemotherapy if you can get it. And then, of course, nowadays you can always do adjuvant nivolumab. And that's also in the NCCN guidelines for those patients who have T2 or above disease who didn't have chemotherapy, or T3 and above who didn't have chemotherapy, T2 and above who did have chemotherapy. So we have a few more options for that individual.
So patients that have lymphadenopathy, you will give chemo and then do the full resection.
Absolutely.
And in terms of outcomes, what do you tell the patients? Those patients that already have some lymphadenopathy there.
Yeah, it's always a challenge to describe what those patients are. And it always makes me think back to bladder stuff, right? So, patients who have known pelvic nodes or even, retroperitoneal nodes, data's not great on neoadjuvant chemotherapy completed by, followed by consolidative surgery. The outcomes and prognosis is fairly poor. So I tell patients that, but I do, now it's 2022 and we do that. It's the best that we've got. And we do have adjuvant options, in today's world.
I remember I had this patient, it was a long time ago, a very small mass in the renal pelvis. I had to take her twice to do biopsies. One was very, very bloody. I just couldn't see anything. Then the next time I did biopsies, and again, it was a small mass. Then I get a call in the post-op, so she went home that day. Like 2 weeks after, she ended up in another hospital. Shortness of breath, she had already metastatic disease to the lungs, and she never had any lymphadenopathy or anything else. I always thought about it, we talk about the water pressure. I mean, I don't know, because it was, the lungs were everywhere. There was masses.
Wow.
And it was a small tumor in the kidney.
Yeah. I think it takes you back to, I think I said it earlier, of don't forget the importance of staging in patients. Yeah, and this patient sounds like maybe, that's a super rare occurrence. But, I think sometimes even when we're doing endoscopic ablations on people, we're seeing them every 3 months, 4 months, we're taking them to the OR, and it's so easy to forget or just get lost in translation of ensuring that you're still doing your axial imaging, you're still looking, because you're so focused in on, oh, there's a new little tumor, I'm going to zap it with my laser. There's something I'm going to, I can get rid of this. And you aren't doing that, right? And again, it takes us back to the guidelines. We don't have guidelines to tell us how often should you be doing axial imaging on somebody who you're endoscopically ablating. We don't have anything to tell us what to do, but especially if you're high grade and that, or it's bulkier tumors, don't forget to look.
Yeah, and like you said, so in that patient, she had the x-ray for the surgery, but just an x-ray, and the x-ray was clear. Maybe she had a CAT scan, definitely, like you mentioned, the staging. So we talk about solitary kidneys. What about patients that have bilateral cancers, or bilateral upper tract cancer? Have you seen one of those?
Yeah, unfortunately, right? That's the nature of urothelial cancer. And it's usually the person who's, still smoking and not going to do any stopping or anything for you. But you got to prioritize. It's just like anybody with any other 2 malignancies, right? And that happens to us. We diagnose lung cancers in urology clinic and all kinds of things. And you figure out which one's the worst one. And it always takes me back, reminder, that the board answer is take out both of their kidneys and put them on dialysis, right? And so I'll tell that to patients. I'll say, okay, if I'm taking a test, this is what the answer is, but we're going to take a step back and we're going to figure out what's going to be our biggest problem, and we approach that. Usually go after the bigger, worse, first, and then see if you can, control and zap the other side. But it does start stretching us on our indications. It's when we're trying to get creative and think of other things to do. Is there a role for BCG? Is there a role for chemoablative, like a JELMYTO in a high-grade patient? There's no data on those things, but that's what we do when we're trying to spare those patients.
Have you done any of those things for high grade? I mean, off-label?
So I have not in JELMYTO. I know that there are many people around the country who have, in palliative situations. So I'm hopeful that that will be published soon for people to see, because that's really the patients, that we're kind of drawing it at straws. We're trying to come up with something. Could you do an ablation and follow it with a chemotherapeutic, more of like what we think of for bladder cancer, for high-grade disease. So no, I have done, and I haven't done this in several years, but, with somebody with high grade, put a stent in, I'm going to try to give them BCG and try to get it to splash up into the upper tract. I don't think it works very well, with that refluxing idea, but I've tried it.
Well, was that in residency or when?
I've tried it in my practice, but I've tried it in residency as well.
Okay.
But like I said, it's been several years since I've done that. I was underwhelmed with results.
And it was a patient with a solitary kidney, or?
Actually, this was a patient with disease on both sides and who now has bilateral nephroureterectomies. But that's not after several attempts, distal ureterectomy on one side, ablations on the other side, eventual nephroureterectomy a couple years later with the other side. So yeah, did we buy 3 or 4 years and not develop metastatic disease? And so we saved 3 or 4 years off dialysis.
Yeah, maybe it's just the nature of the disease. I mean, who knows?
Yeah, hard to say.
Okay, yeah. Any other comments? I think this has been great.
Yeah, I don't think so. I can't think of anything else, and I think in conclusion is kind of going back to what you said at the very beginning, this guideline thing. And it's important for us as urologists, important for doctors, all over. And so we can look to the NCCN guidelines, but they're not the same. They're not urology guidelines, so it'd be nice to have some of those to help guide us in some of these more difficult situations, because the bladder guidelines are there. We can extrapolate as much as we want and as much as we try, but the bladder's not the renal pelvis. The bladder's not the ureter. And the implications of diagnosis, the implications of treating those are different.
Yeah, so hopefully, do you know if the AU is working on it, or?
I've heard talks, but I've heard people talk about it, but mostly in the way that you and I are talking about it. Like, yes, we all need this, but I don't have enough insight into what's happening in AUA and guidelines. So
maybe after they hear this episode, they come up with one.
There you go. There you go.
So, Katie, we have here Dr. Murray. Thanks for being here. It was a pleasure. And yeah, I enjoy it. I know more now. I feel more confident doing more stuff. Looking for patients to do JELMYTO. I mean, for me, it's a rare disease. I think in the past 3 years, I have seen maybe 2 or not even 3 patients.
They'll come up. They do. Those patients are out there. And so just keep your eyes open and patients show up.
Thank you.
Thanks.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz, with support from
Ishan Sangwan
and Vedavi Patwardhan.
Social media and PR by Chi Ding.
Thanks again for listening, and see you next week.